Welcome to the Psychosocial Oncology Training Academy. I'm here today to present to you on breast cancer diagnosis and treatments. Funding for POTA has generously been provided by the Women's Breast Health Fund and Community Foundation of Greater Birmingham. My name is Gabrielle Rocque, and I'm an associate professor of medicine in the divisions of hematology and oncology, as well as gerontology, geriatrics, and palliative care. I'm a breast medical oncologist with research interests in quality of healthcare delivery and with an emphasis on shared decision-making and supportive care services to patients. I have no conflict of interests. Today, I'm going to talk to you about how breast cancer is diagnosed. I'm going to help you identify the most common types of breast cancer treatment and understand how treatments are chosen based off characteristics of breast cancer. Breast cancer is the leading cause of death for women in the United States. So many of you will wonder, how do I screen for breast cancer? Breast cancer is screened for using mammograms. Mammography should start for women age 40 to 44, and they have the choice to start an annual mammogram if they wish to do so. And this is really shared decision-making between the patient and their provider. Women age 45 to 54 should get mammograms every year, and women 55 and older may switch to mammograms every 2 years or continue screening yearly. Screening should continue as long as a woman is in good health and expected to live for at least 10 more years. And all women should be familiar with the known benefits, limitations, and potential harms linked to breast cancer screening as recommended by the American Cancer Society. In addition to this, anyone with a breast mass, regardless of age, should receive an evaluation with a mammogram. So who's above average risk? The recommendations that I provided on the previous slide showed those that are at average risk. But women who have genetic mutations, such as a BRCA mutation or any other breast cancer-associated mutation, as well as their untested family members, would be considered at increased risk and should have earlier screening. In addition, other women who have a greater than 20% lifetime risk, based on models that help predict risk using family history and other characteristics, should also be in a different screening category, as should those women who have a history of radiation, particularly mantle radiation to the breast, or other cancer syndromes. Ultimately, people with a family history of breast or ovarian cancer should talk to their doctors about their personal screening plan. When we diagnose breast cancer, we think about several different factors. First, we consider the tumor size and how big that tumor is in the breast. We also consider whether that breast cancer has spread to lymph nodes or other distant organs. When thinking about the size and spread, stage 1 through 3 are considered early stage breast cancers, and those include individuals who have not had any cancer spread to any distant organs outside of the lymph nodes. In contrast, those who have stage 4 or a recurrent breast cancer are considered a late-stage breast cancer and may have involvement of organs such as the bones, lungs, liver, brain, etc. We offer several types of treatment for breast cancer. The mainstays include surgery, radiation, and medical therapies, which can include chemotherapy, targeted therapy, hormonal therapy, or immunotherapy. When we're choosing treatments, we take multiple things into account, including the stage of the cancer, their receptor status, particularly their estrogen, progesterone, HER2, and more recently PD-L1 status, as well as the toxicity profile of the treatments that we're offering. It's important to consider patient characteristics and preferences, particularly in places where there are multiple treatment options with varying intensity. And finally, I cannot forget the importance of clinical trials and the availability of those trials that we can offer to our patients. When thinking about the order of treatments for early-stage breast cancer, we typically choose either a neoadjuvant approach, in which the chemotherapy is given before surgery, or an adjuvant approach, in which case the surgery is done first, followed by chemotherapy. After the surgery and chemotherapy are complete, if the patient is going to have radiation, that would traditionally come next, followed by the endocrine or hormonal therapy that they're likely to be on for several years if they have a hormone-sensitive breast cancer. When thinking about surgery, we use several different types of procedures. A lumpectomy is a smaller surgery in which only the tumor is removed. In contrast, a mastectomy removes the entire breast tissue. We also have a lymph node evaluation. A sentinel lymph node evaluation looks specifically at the first lymph nodes that the cancer would travel to, and potentially an axillary dissection, which includes removal of all of the lymph nodes. In terms of the medical therapy for chemotherapy and targeted therapies, for early stage disease, we usually are giving chemotherapy at a frequency between weekly and every 3 weeks. Patients have their nadir, or lowest point of their blood counts, usually in the middle of that cycle. For some treatments with chemotherapy, we use growth factor to help support those blood cells to make sure that they're sufficient to continue treatment. And that really helps us keep patients on target. In this setting of early stage breast cancer, we have a higher tolerance for side effects due to the potential for cure. In terms of hormone therapy, this is given to all estrogen and progesterone positive tumors and is very important. This allows for approximately a 50% risk reduction in that patient's risk of recurrence. And it's very important to take all doses and emphasize adherence. Patients will usually be on this for a minimum of 5 years, with many of them extending up to 10 years for additional benefit. For radiation, this typically lasts 4 to 6 weeks, although this can depend varying on the plan, and different programs can be offered to specific patients. This is given for almost all lumpectomies and some mastectomies for larger tumors or more involved lymph nodes. This can overlap with targeted and hormonal therapies, but is usually done following chemotherapy. For metastatic breast cancer, this is a different course of treatment. In this situation, we traditionally provide medical therapy until progression, followed by subsequent rounds of additional medical therapy. We often try to use the better tolerated treatments early on, anticipating that patients may be on these therapies for some time, and then less tolerated treatments and more aggressive treatment as the cancer progresses and becomes more resistant to our early treatments. We also use radiation or surgery to manage specific problems, but the mainstay of treatment remains medical therapy.